Hi, everybody, and welcome to Psychiatry Redefined's free Lunch and Learn webinar today. I'm Cindy Hale. I'm part of the team here at Psychiatry Redefined. We're thrilled today to have Dr. Mariela Podolski, who is going to be talking about incorporating functional psychiatry in your clinical practice. Dr. Podolski is a dual certified clinical psychiatrist, adults and adolescents. She's originally from Costa Rica. What a great place to grow up. And she now lives in Connecticut. She has taken both our general fellowship and our pediatric fellowship, and she's now part of our faculty. And she has an incredibly successful practice in Connecticut that is in greatly due to being a fellow and all that she's learned how to integrate functional psychiatry into her conventional practice. So with that, I'm going to pass the baton to Dr. Podolsky. A couple of housekeeping things. We will send everyone a link to this webinar afterward. And all questions, please put in the Q&A section and not in the webinar chat, and she'll get to them at the end. Thank you so much and enjoy.
Thank you so much, Cindy. I hope everybody can hear me okay. I'm thrilled to be here. As Cindy said, my name is Mariela, last name Podolski, and most people call me Dr. P just because it's a little easier to say. Um, I'm a child and adolescent psychiatrist, and my practice is very, very successful. I'm very grateful for that. And as Cindy said, the main thing that differentiates me from other psychiatrists is my functional approach, which I learned in Psychiatry Redefined years ago when I decided to do the fellowship. So let's get started. Um, oh, wait a moment. Technical problem. Nope, right there. Sorry. There you go. Okay. Bridging the gap, integrating functional psychiatry into traditional psychiatric practice. For all of you who are thinking about this, I can tell you, you won't regret it for 1 minute. What was my journey to integrative psychiatry? As Cindy said, I was born and raised in Costa Rica, and I moved to the United States when I came here to do my psychiatry residency in 2007. So I was an adult. I went to medical school in Costa Rica. I had a pretty traditional training, medical school at Universidad de Costa Rica, and then I did my residency at the Institute of Living in Hartford and my fellowship in child and adolescent psychiatry at the Medical College of Wisconsin. The talk about functional psychiatry was not a thing in any part of my traditional training. And in preparation for this talk, I went and looked up my biochemistry book. This was the book that we used. And I looked up like what was the, synthesis of serotonin. And I remember really struggling with all of these names and what they meant and what it was. And I didn't know that in the future I would be really interested in understanding a little bit more of the biochemistry and how that affects mental health. And it all came full circle. Um, During my fellowship in Wisconsin and Milwaukee, I had an adolescent medicine doctor come and ask me this question. Where are there some kids who respond to fluoxetine 10 milligrams and others need 60 milligrams? And in my ignorance, I answered something like, well, the starting dose really, you could start low, but the target dose should be 20. And I don't know that it's reasonable to keep somebody underdosed if you're going to give a patient a medication anyhow. And now I really regret it. Having learned so much through the fellowship and having understood so much better about metabolism of medications and how everybody is unique and different, I now know the answer to this question has a lot to do with how you metabolize fluoxetine in particular through the pathways in the liver, the CYP450, which genetic testing can tell us about. So a lot to learn. Also, in preparation for this talk years ago, I said, okay, let's see if a primary care doctor or a pediatrician or somebody who is not trained in psychiatry had a patient in a rural area that wants to start on medication for depression, what would up to date at the time was my main source of information, what would we use? And so I looked this up and I am screenshotting exactly what the up-to-date database says. So it's a combination typically of pharmacotherapy and psychotherapy. And then it tells us a little bit about how fluoxetine is going to be the first line pharmacotherapy option. And there is no talk about anything else. It just says, well, if there was somebody else in the family taking something else, maybe like consider that. But it really doesn't say much more. It just says if a kid is depressed, start them on fluoxetine. Now we have open evidence. If you're not familiar with open evidence, you should be. It's AI for medical care, and it can give you a lot of data in a very short period of time. But I put this in the web search in their search box, depression treatment for adolescents. And what they tell me is treatment of adolescent depression follows a stepwise severity-based approach, combining psychotherapy and pharmacotherapy, fluoxetine as first line. So even though years later, I posed that same question to one of the biggest AI search engines for medical care, the answer is not different. And in my practice, after doing the fellowship, I have learned this question can be really answered by so many different things. And that's what I want to share with you today. Before I worked in my current private practice, after I graduated from fellowship, I was working in an area that is underserved, and I had 15 minutes per appointment or 20 minutes per appointment, and I had tons of patients to see. And I felt like I was literally carrying an elephant on my shoulders every day. It was medication after medication, little kids, younger kids, kids as young as 4, 5, 6 years old on tons of meds, and my patients didn't necessarily get better. I disliked my job with a passion. I couldn't wait to get out of there, and I wasn't really satisfied with psychiatry, and made me rethink why had I gone into this practice. And I promised myself that I would never do outpatient psychiatry again. As you know, I already spoke about this. I'm board certified in adult psychiatry and child and adolescent psychiatry. And my other area of interest is eating disorders. And I work with a lot of patients in those areas. Since doing the fellowship in 2020, I have really incorporated these little tidbits of things that have completely shaped how I work today. And I haven't given up my prescription pad, as Dr. Greenblatt, the founder of Psychiatry Redefined, says. I'm not. I still use medications, but I can tell you I use medications in much less instances that I did before. And also, the dosing of medication tends to be less. And that is incredibly satisfying. And my patients really, really appreciate getting better with other interventions. So I'm going to go through many of my clinical cases that I have accumulated over the past few years and share them with you. And we can leave some questions for the end. And so these are things, the reason I'm doing this is because I want every clinician that is present in this meeting to see themselves being able to do these things. These are not complicated things. These are things I learned in the fellowship and that I apply every day, and that have truly shaped the way that I practice psychiatry. And I can't look back. It has to be this way. I know it is the right way. So I'm going to go back to 2012. This is when I had just graduated fellowship, and I didn't know much about functional psychiatry, anything. But I had Megan. Megan was a 17-year-old girl with anorexia. She had been weight restored for a period of time. And if you know, in anorexia nervosa, weight restoration is linked to your mood. But in this case, she was still very depressed, and she was having a lot of difficulties socializing. She was really anxious, paralyzed by fear. And when she came to me, she was on escitalopram or Lexapro 20 milligrams per day, and the response had been literally minimal, if any. And so at the time, there was this new thing about genotype testing. I was not very familiar with it, but I decided to utilize the information. So we ordered it, and this came back. So it came back that in her cytochrome P450, she had in the 2C19 pathway. She was an ultra rapid metabolizer, which meant that the dose that citalopram, that is a medication that is metabolized through that pathway, well, she was metabolizing it so fast that she wasn't building a good level of that medication, and hence there was very little to no response. So I went above the FDA approved dose, which is 20 milligrams. With that justification, I increased it to 30 milligrams. And I also found that in her methyl tetrahydrofolate reductase enzyme, she had a TT mutation. And that told me she's not able to metabolize folate into the active version, which is L-methylfolate, that then allows our patients to really utilize that L-methylfolate to synthesize our neurotransmitters. So all of this connected was, okay, let's increase the escitalopram to 30 milligrams and add L-methylfolate 15 milligrams a day. Now that's something I no longer do. I started much lower, but this was years ago when I really was kind of just starting. And that I don't want to suggest that you should do that, but that's what I did at the time. And what happened with her was that she got incredibly better in a short period of time. And because life is full circle, as I was getting ready for this talk, she just emailed me earlier this week saying, "Hello, Dr. Podolski, I hope you remember me, yada yada. I'm now a therapist and I would love to collaborate in some cases." So that was phenomenal. She doesn't know that I use her in my presentation, and obviously I'm protecting her name, but it's something that was very rewarding for me. And this was my first functional psychiatry patient without me knowing that I was doing functional psychiatry. Now I'm going to share some patients that I have seen in my current private practice. And these are just cases. I'm going to go through all of them. So let's talk about Henry. Henry was 16 years old when he came to me. And what he came here for was because he had tics. He said it started in my face, now it's on my neck and my face as well. And it had been happening sometimes, but now it happens every day, getting worse. And it was making him really anxious. He really didn't have any other psychiatric symptoms, and he was doing well in other areas of his life. And so I did some labs. And this is what I found. His vitamin D was 31, so it wasn't super low, but it was also not optimal. And so we decided to start him on a supplement of vitamin D. But also, I had learned in the fellowship that magnesium can be incredibly helpful for tics. And so I started him on magnesium glycinate, which is better tolerated and better absorbed, and started him on a dose of 240 milligrams twice a day. And what happened? He had complete resolution of symptoms within 3 weeks. It was like miraculous. Now, he went away for some vacation, stopped taking the magnesium, and the tics returned. So when he came back from vacation, he came to my office and he said, "I'm again struggling," and told me what had happened. We started the magnesium again, and he had complete resolution of symptoms again in 2 or 3 weeks. So he discharged from my practice. I no longer need to see him. Now, why am I bringing up this case? It was a very simple intervention, straightforward. I learned this in the fellowship. And what I had learned in the Psychiatry Redefined Fellowship, what I had learned in my regular child and adolescent psychiatry fellowship, is that tics were treated with either guanfacine or clonidine, and that would have required a prescription that probably he would have been on for a very long period of time. So significantly different approach, excellent results. Let's talk about Anna. Anna is a 13-year-old girl, and she comes to me after the pandemic. She had had anorexia nervosa during the pandemic, and she had done treatment, really basic treatment with adolescent medicine and psychotherapy, and she was in a much better place with her eating disorder. Now, she had started to struggle again, and reporting a lot of sadness, crying spells, not being able to participate in school, not liking things that she used to like and enjoying those things, fatigue, low motivation, etc., etc. All of the real significant depressive symptoms, and being anxious all the time. She was on no psychiatric meds. And as I said before, with my other anorexia patient, she was weight restored. So this is not due to malnutrition. So anyhow, we did labs, and this is what I found. So she had a zinc level of 73, and that is not super low, but it's not optimal. Her vitamin D was deficient. She was deficient in vitamin D, and again, she had MTHFR. She had that mutation. She had TT, that variant, And as Dr. G says, T is for trouble. So what do? This was my treatment plan. L-methylfolate, 5 milligrams a day, vitamin D, fish oil, a multivitamin every day, and zinc every day. When she came back to her follow-up 2 months later, the mom literally said, it is like a miracle. She had returned to her after-school activities, mood had improved, fatigue lifted, everything was fine. And she was again discharged from my clinic. That is the one thing that I have in my clinic. My patients do leave me. So, and people ask me, are you still taking patients? And I say, yes, because my patients get better. So I always have space for more. Let's talk about John. 10-year-old boy. This is one of my first cases that I treated with real functional psychiatry. He had been in a binge eating disorder program, close to 250 pounds, really, really struggling. ADHD was his other diagnosis, and he had a good, my non-functional psychiatry training had taught me to treat this kid with lisdexamfetamine, which is Vyvanse, and topiramate, which is Topamax. And he had done relatively okay. He was doing okay. Now, 6 months later, he comes, the parents come and tell me he's very defiant. He's having a very hard time at home and at school, very aggressive, physically aggressive, irritability, slamming doors, things that they were not seeing before. And it has become very evident that he's also impulsive, using a lot of profanity, grabbing objects, stealing from his parents, and what he identified as being in the quote unquote gang culture for his terms. And all of his labs were normal except vitamin D. So what did I do? As I learned in the fellowship, I requested to have a hair mineral analysis. And here we can see all of these minerals. And if you look, we can see a very elevated copper and normal zinc and a very low lithium level. And this is what I learned from the fellowship. When we see this imbalance in copper and zinc and very low lithium levels, absolutely these patients can present with very significant explosive behavior and difficulty regulating their emotions. It was very simple. What I did, I added 5 milligrams of lithium orotate, maintained the vitamin D, and added zinc 30 milligrams twice a day. The parents reported such significant improvement, the school called me, telling me that they had never seen something like this within a few weeks of starting the zinc. He was so much better and they could work with him at school. He had been on a PHP waiting list because this is just after the pandemic and the waiting lists were so long and he couldn't get in. But at the time that his spot opened, it was no longer needed because he was feeling so much better. I have to share with you, I still see him. He's no longer on any medications other than a multivitamin and Vyvanse because he still has ADHD, but he's on no other medications or supplements. His levels are good and he's thriving and doing incredibly well. Let's talk about Frank. Frank is a 16-year-old boy attending boarding school. He had been treated by a different psychiatrist since young, had a history of anxiety, depression, a lot of difficulty with transitions. It's a question mark if he was on the spectrum, diagnosis of ADHD and MDD, but for me, spectrum was a big question. Panic attacks, unable to leave home, unable to see friends, go back to school. He was having suicidal ideation, feeling really stuck and medicated for years. When he came to me, these were his labs. So of concern, his homocysteine level is 53.5, which is very elevated. He no longer holds the record of the highest homocysteine level that I have seen. However, that is pretty high. And his cholesterol level, his total cholesterol is only 112, which is very low. So those were concerns for me. And what do we do? Well, I started him on maintained his medications that he was taking, but I added fish oil. I increased his fluoxetine, added fish oil, and started him on homocysteine factors to lower the homocysteine. His MTHFR was also TT. So what happened with him? In about 4 weeks, he felt so much better that he was able to return to school. He continued to have anxiety and obviously needed psychotherapy, but he no longer had suicidal ideation and he no longer had panic attacks. And yes, I did increase the dose of fluoxetine, but what was key here was lowering that homocysteine level that can be associated with so many psychiatric symptoms and also other symptoms in the long run. But for what it's worth, for my case, in terms of the panic attacks and the hopelessness, that improved significantly. And it is my clinical experience with lowering homocysteine that that's the case. I'm going to talk about Mary. Mary is 12. She has a previous diagnosis of ADHD and generalized anxiety disorder. She has been engaging in all types of risky behaviors, leaving the house in the middle of the night, meeting with boys. She was only 12 years old when this was happening, and she had a lot more irritability. Impulsivity was very clear. Academically, she was struggling, which had been a different a difference from her baseline, despite her having ADHD and being medicated for it. Now she was struggling a lot more. She had been medicated before I had seen her with citalopram and amphetamine salts, and she had been doing relatively okay until the time that she came to see me with all of these symptoms. And so this is what we found. I ran some tests, and her zinc was low. 69 is not super low, but it's not optimal. Her vitamin B12 was 384, which, as you see, it is reported within the normal range. However, that is also for Quest, they also say, well, but if you are between 200 and 400, between 5 and 10% of patients may have neuropsychiatric symptoms. So for me, that is so contradictory. And so what I learned in the fellowship is we want to optimize the vitamin B12 to 500 or so. And so I tried to do that. She also had a vitamin D deficiency at 26. But the one thing that we also did, I supplemented her B12 and added vitamin D. I also added, as I said, I used my prescription pad, so I added guanfacine extended release, 1 milligram for the impulsivity. But what was marked was that she had this elevated cryptopyrrole. Cryptopyrrole is one of the tests that you'll learn about during the fellowship, and that has really incredible clinical implications. When we have elevated cryptopyrrole, we know that zinc and vitamin B6 are being excreted in excess, and that can be a big concern because it leads to deficiencies, functional deficiencies of vitamin B6 and zinc. And so we added zinc and vitamin B6, and that's all we did. And 3 months later, the patient is doing fabulous with decreased impulsivity, decreased irritability, and conflict with parents is decreased as well. I can give you an update on Mary. She's still my patient. She is 18 now, and she does need her Adderall for her ADHD. However, she's no longer on Celexa, no longer on guanfacine. She's doing incredibly well. And when we repeated the cryptopyrrole, it continues to be borderline despite her supplementing. So she will continue to supplement probably for the rest of her life, but we don't know that yet. However, those supplements have made a significant difference for her. Because I work with adults too. Let's meet Adam. He's 60 years old. Major depressive disorder, severe, very stressful life. He has an adopted child with very severe aggression. And he had been relatively stable in terms of his mood for many years on bupropion extended release, 450 milligrams a day. And unfortunately, in the past few months, he had been unable to get his day started. He just felt so depressed, no joy, no energy to do anything, a lot of guilt, having suicidal ideation. What's the point? I'd rather die. Pessimistic, fatigue that goes beyond normal. And so these were his labs. And these are things you can check for in your office. You don't need any fancy, you know, any fancy equipment to order these labs. Something as simple as a vitamin B12. being low at 239, significantly less than optimal. But more importantly, that vitamin B12 also having an impact on the level of homocysteine, and now the homocysteine level is elevated, and a low vitamin D. Those are things you can test for in your office without a problem. Because what would I have done for this patient had I not known this? I would have added probably Prozac for him or another medication because he was maxed out of the Wellbutrin. Instead, I checked his labs, and this is what we did. I ordered a subcutaneous methylcobalamin to optimize his vitamin B12, added vitamin D3, fish oil, and did give him inositol as a supplement to help him with sleep, something that I also learned in the Psychiatry Redefined Fellowship. I maintained him on the shots for 2 months. His B12 level normalized, and this is his report. His improvement is so drastic. He is able to tell me, Dr. Podolski, I have never felt this good in my whole life. I feel the best that I have ever felt. No, and there was no change in his environmental stressors, meaning all of these supplements were really the cause for him feeling better. And these are things that I was not taught to order when I was doing my training back then. When Charlie, this is a sad story. This is not this is not a fabulous story. It's a sad story. He's 26 and he has a diagnosis of schizophrenia paranoid type. He had been hospitalized twice. At the current time when I met him, he had been working at a supermarket and he was on clozapine. Clozapine is an antipsychotic used for schizophrenia, has multiple medical implications, and it's hard to manage. But he was in clozapine and he was doing relatively okay. I mean, he wasn't thriving, but he was stable. He's vegan and is not willing to change his diet whatsoever as part of his delusion, and has some paranoia at baseline. Also he has negative symptoms with abolition and blunted affect and alogia. And there is delusional thinking. He has conspiracy theories that he struggles with, and oftentimes you would see him responding to internal stimuli. So definitely he was psychotic, but managed. And I ordered his parents were really on board with the functional testing, and we found so many abnormalities. He had elevated HPA 374, and this is something I learned through the fellowship. We can order something called organic acid test, and it measures this byproducts of one of the Clostridium species, and that he had elevation of. And we know that that byproduct prevents the breakdown of dopamine. And when that happens, psychosis can be present. There are other symptoms that can happen, but in his case, it was very clear that he was so psychotic, and this was found during his testing. His cryptopyrrole was borderline, so I know that he was also wasting away zinc and vitamin B6. And this is his hair mineral analysis. As you can see, all of his minerals, all of them, are low. So what we are seeing is a brain that has very low nutrition. He's very malnourished at the micronutrient level, and also he has dysbiosis and he has elevated HPA, as I explained before. And I can guarantee you this was 100% part of his clinical symptoms. Unfortunately, despite multiple recommendations and regimens to help him and supplements to help him, he refused, and he was unable to comply. And he remained psychotic. He no longer is my patient because he just didn't want to continue treatment. On a more positive Laura, 12-year-old, initial evaluation during the pandemic with a lot of emetophobia, which is the fear of vomiting. She had weight loss due to stress, to being unable to eat. She has social anxiety, unable to stay in class, panic attacks, all types of things. I was not able to get blood work because she was afraid of needles. So I started her on 25 milligrams of sertraline, which is pretty standard dose for a 12-year-old to treat what I thought was generalized anxiety disorder, OCD, and the panic attacks. the dose of sertraline was optimized to 100 milligrams, and there was improvement for sure. She was doing better, able to eat in the cafeteria, participate in class, but still struggling to some degree. She has a lot of nausea, a lot of palpitations and sweating. And 2 years later, I was able to convince her to go to the lab. And so I said, you know what, I'm going to test for everything I can think of. And these were her results. So she has low vitamin D at 21. Her vitamin B12 is also low. Her ferritin is only 5, so she is extremely iron deficient. And she has also celiac disease. That was my first case of celiac disease that I diagnosed in my office, and it was a complete surprise. So after the celiac disease diagnosis, of course, she went gluten-free, and we started working on lowering the dose of sertraline. And she reported minimal anxiety, no panic attacks, no heart palpitations. Her iron has normalized because she can absorb it now, no nausea, and able to go to school and stay in class and see friends. And that was one of the most rewarding cases that I've had. Since this girl who came to me, I have more like 400 patients now. This is an old slide. And I have included celiac testing in every of my new patients. I am proud and happy to say that I have been testing since 2023 in October, so almost 3 years, and I have about 15 new diagnoses of celiac disease in my office that had no GI symptoms whatsoever. And what is incredible is all of them have improved their symptomatology, their psychiatric symptoms when they come off gluten. I'm not a fan of recommending people to be off gluten unless there is a reason. And so this has really helped me target those patients who would benefit from a gluten-free diet. And it makes an incredible difference. Something I also learned in the Psychiatry Redefined Fellowship. I want to talk a little bit about Lyme disease because, well, I'll tell you why. I live in a pretty endemic area of Lyme disease in Connecticut. We have a lot of Lyme disease. And so I added this to my initial workup for every and all patients. And the reason is because I missed 15-year-old male who had been treated with multiple psychopharmacological interventions for depression and anxiety and have no response. I missed that he had Lyme disease. And so I started testing everybody for Lyme disease. And by the way, just today, life is always full circle. Today, I had a patient who I didn't test her, but we did talk about a potential test for Lyme disease because she had to take a medical leave from school due to severe fatigue and depression, and ended up she had Lyme disease. So that's always good to keep in your differential. Let's talk about Richard. Richard was a referral from a local therapist. He has Tourette's and ADHD, and his tics are so severe, he's unable to complete one sentence without stuttering. He's stuttering all throughout. Every 2 words he stutters. Has vocal and motor tics that are very evident. He's so self-conscious about this. He feels really uncomfortable in social settings, and his ADHD symptoms are present and interfere mostly with his academic performance. And so I tested him for many things, one of them being also Lyme disease, and he had Lyme disease. Right on top of that, he has a mutation for MTHFR. You can see it here. He has a T in this part of the gene, and then he has a C, so he has two variants. And so he has an MTHFR mutation and he's positive for Lyme disease. So of course I sent him to the pediatrician and they treat him for Lyme disease, and just with Lyme disease treatment, tics and stuttering decrease about 50%. I asked them to start L-methylfolate and magnesium after they had completed Lyme disease treatment because I didn't want that to interfere. And so they did start magnesium for tics and L-methylfolate, as we had discussed before in other cases. And this is what I got from Richard's parents. And I'm sharing for you not because I want to toot my own horn, but because I want you to feel empowered so you can see that this is something so simple that you can also do in your practice. As a parent who is very invested in my child's well-being, I wanted to explore options outside of the traditional prescription medication processes that we had been dealing with my son's ADD and slight Tourette's condition Both of these conditions were contributing to his tics, restless sleep, and constant movements while seated. Once we incorporated the methylfolate and magnesium supplements, both our therapists and psychiatrists noticed a drastic change in my son's tics and movements. Most importantly, my son could feel the difference and told us so, especially when he missed a full day of vitamins to prepare for a urine test for one of the doctors. He had trouble falling asleep that night and told us he could just feel a difference and didn't like how he felt. Incorporating these vitamins has made a huge difference for my son, and I am so thankful to currently not be on any medication for his ADD. Clearly, that is not the case for everybody. Some people do need to take medications for ADD. However, this is an incredible case and he got so much better. And as his psychiatrist, it made me feel really optimistic about my patients and my ability to treat these cases that are a little bit more difficult. This is John. He's 15 years old and he's from Washington, living in Connecticut for school. He's attending boarding school. And he has a history of anxiety for which he had been prescribed Lexapro for the past 6 months. He becomes increasingly unmotivated, disinterested in school, has a drastic change in the way he's behaving. He went away for vacation and he became incredibly isolative, unengaged, saddened, depressed. The parents were incredibly concerned. And the symptoms worsened to the point, that he was skipping classes and having a lot of things, but he became suicidal. And that was a very, very, it was an emergency. Like the parents had to come all the way from Washington to pick him up because he had suicidal ideation with a specific plan that he could have gotten to. His parents pick him up and bring him home, and where he's hospitalized and started on Prozac 10 milligrams and followed by intensive outpatient and outpatient therapy that he attended really for only like 2 days. So he really didn't do that. During this period of time, we were trying to figure out like how could I help them, but they were out of state, so there are regulations around that. But I said, let's order the labs. And so what ended up happening is that this boy had mononucleosis. So he was positive for Epstein-Barr virus, and that explained his fatigue, his lack of energy, his inability to interact with others. And that was the diagnosis. It was not depression per se. I mean, he has a history of anxiety, so I think like keeping him on the Prozac was reasonable, but we had to take into consideration that he also had mononucleosis. And you would say, like, what is a child psychiatrist doing testing for mononucleosis? Well, this is exactly the reason. I learned all of these things in the functional training, and they have truly made a difference. We coordinated with his psychiatrist back home. The treatment plan obviously changed because we found this, and family and patient felt incredibly reassured that he was going to be okay. He returned to school, and after 6 weeks of his suicide statement, and was able to complete the year without any problems. And I think this is my last case, and also one of my favorite cases, because it's kind of like the sum up of all of the above. 15-year-old girl, meeting criterion for depression and major depressive disorder and generalized anxiety disorder, unable to enjoy things that she used to, overwhelmed in social situations, unable to participate. She said, I can't talk much. It is too overwhelming. Like she just couldn't say words. Her mood was very low. Her energy was variable, but often low. She needed to take naps. A lot of thoughts of, I would be better off dead. What's the point of living? That kind of thing. Just heartbreaking. And so these are her labs. She's iron deficient. Her ferritin is 12. Her vitamin B12 is 432. Her zinc in the red blood cell, which is what I use, I have learned to use that through the fellowship, is 7.1, so it's very low. And her vitamin D is also very low at 21. So what was her treatment plan? This is in October of 2025. We start with supplements, and the supplements are vitamin D3, iron tablets, zinc, fish oil, and vitamin B12. By January of this year, so just a few months later, She has complete resolution of symptoms. She's able to participate in social events. She has no more naps, no suicidal ideation. All of her levels and her repeat labs have normalized. And she tells me, I feel fine. I feel back to myself. I don't, there's nothing else to be done. So she's, again, discharged from my clinic. And that was that. And so I think, again, going back to my original point, and the reason I'm here is because this should be the way that we all practice medicine. And even though it sounds complicated now, as you go through the fellowship, you'll find these things to be easy to do and really life-changing for our patients. So just to share with you, after the first call, when a patient calls my office, I do genotype. Well, I offer. I don't mandate these things, but I tell them I can really, really help you if I have all of this information. So I do genotype testing on all of my patients. Medicaid and Medicare covers it. So if you have if you work in an insurance-based practice, Medicaid and Medicare covers genotype testing, and I order all of these labs that are here: magnesium and zinc and CBC, iron, Epstein-Barr, Lyme, vitamin B12, a lipid panel, comprehensive metabolic panel, vitamin D, celiac disease panel, and homocysteine and thyroid. And so these are, simple interventions. They're helpful and they're available to all of you. Simple lab order can help you identify the uniqueness of everybody. Dr. Greenblatt always says that we're unique as like the zebras are. There's no two zebras that are the same, and that is true for us too. And I use this quote, my quote unquote, I say, your neurotransmitters are created similarly to baking a cake. If when you're baking, you only add 2 eggs instead of 4, or half a cup of sugar instead of 1 cup, you can still bake a cake. It just won't be a good cake. It will come off, like it'll be off, right? Like the texture is off, the taste is off. And so it's the same with our brains. All of these vitamins and minerals are the ingredients for your neurotransmitter recipe. And so let's give your brain the things that it needs to work at its best. And oftentimes, that was all we needed. I want to remind everybody that plant-based diets, people who are not eating iron, zinc, and B12 because they're eating plant-based diets without meat or animal protein, they get very deficient in those 3 things that are essential for neurotransmitter production. So that's a red flag always. Ask them what they're eating. I do find that compliance is a major obstacle with my patients. So taking all of the supplements takes effort, and sometimes it's too many of them. And so I tell my patients, let's do this for a period of time and then we retest. And after we retest, we optimize. So hopefully we can take less and less. Some of my patients, once they have normalized the levels, we can transition them to a multivitamin, and that's all they need. Am I an integrative psychiatrist because I offer additional testing to everyone? Well, if you want to become somebody who practices functional psychiatry, these are my tips. Start small, go slow. If you do the fellowship, you'll learn little bits one at a time, and you'll get more and more experience. This is new information. It was like going to med school again. And find your people and ask questions. There's a lot of us now that are interested in this way of practicing, and you'll always find somebody who is willing to lend a hand through the community that Psychiatry Redefined can offer you. So I go back to this. Now that you have heard me talk about my cases, and I shared all of these are my cases that I have had in my office, is this correct? Is up to date correct? I would say no. There's so many different ways that we can practice. I feel like I have seen the light. For me, there is absolutely no way that I can go back to practicing psychiatry or medicine the way that I did before doing the fellowship. And I urge all of you to take that into consideration. Look at it. You might find a lot of answers. And finally, do or do not. There is no try. We owe it to our patients. We owe it to the people to get better, to feel better, is to practice medicine the right way. And for me, this is the way. That's it. I am open for questions.
Mariela, they're in the Q&A section.
Oh, sure. I'm sorry. Let me take a look. I'm going back. I'm sorry, just finding. Please happy. Okay. Okay. Let's see. Hormone intensive. That's other questions. Is that in the webinar chat or is there another area, Cindy? Oh, here, it's the Q&A. Sorry, I was in the wrong place. Okay. I have a burning question about evidence-based practice as seen in the beginning of the presentation. How then support the I think the question is about the legal scope. I don't think that I'm gonna answer that question very quickly. I mean, there's like a lot of specifics. But for instance, is the ability, like I think the question is like, is this evidence-based? And so this is the ability of us as clinicians to incorporate other things that are possibly affecting our patients from a medical perspective, creating and mimicking psychiatric symptoms. And there is a lot of evidence for that. So, for instance, one very simple thing, like when you actually study depression as a medical student, probably there is, well, not probably, there is mention of iron deficiency anemia as being one of the causes, but we as psychiatrists do not look into that. Like this is not something that we do. So yes, there are a lot of evidence-based things that you can find, but what the fellowship is going to really provide you with is the ability to incorporate all of those things into the clinical case, which I find that is the missing link. Affordable pharmacogenetic testing resources. How to get these recommended labs covered. I mean, the recommended labs are typically covered by insurance. I mean, you just have to order them. And the affordable pharmacogenetic testing is not very affordable, but most of the companies do have a way for it to have like financial aid. I think they are around $300. And as I said before, Medicaid and Medicare do provide, they cover the genotype testing. How can we offer functional lab testing and other testing in an affordable manner? Well, that's a problem. Unfortunately, I'm not necessarily in charge of the pricing. It should be covered by insurance. It isn't yet, but I dream of a day that it will be. So are there prior auths? Typically not. Typically you have to pay for them. But as again, I talked a lot about other cases in which just the quest draw, like the lab draw, like the blood, is enough to make a significant difference. Most of my patients, I don't start with the more elaborate testing like an organic acid test or a hairy mineral analysis or a cryptopyrrole or even Intellex DNA. I don't order those ahead of time. I only order those in some cases, and um, blood draw is enough. What is your source of methylcobalamin? I use a compound pharmacy particularly, and that has worked very well. How do we use functional approaches without trending towards a more wealthy clientele? Again, I think I just answered that question in a different way. When I don't think that any of my basic interventions, which are the 90 or 95% of the interventions that I do here, have anything to do with a patient being uninsured or Medicaid or having very little resources. A Quest Draw should be covered by insurance, and it can give you a very, very significant amount of information that is going to make a difference. What is the difference in MTHFR TT versus CT? Well, you absolutely can take the fellowship and find that out, but it has to do with the percentage of that enzyme being slowed down versus not. So TT is 70% versus CT is only 35%. Do you do the same lab panel for all patients? Yep, I do. And there's insurance coverage. Can you speak about comp genotype variants? I don't think that we have time for that, but that's definitely something we cover in the fellowship. What companies do you use for laboratory testing? I use Quest, but you can use LabCorp as well, or maybe there are others. how often do you see significant improvements with supplements alone? So by the time patients come to me, most of the patients don't want only supplements. So I couldn't tell you that that is the majority of my patients. But I did share with you some cases in which supplements alone were enough. And that's not uncommon for me to see. Highest recommended dose of magnesium, that depends on the kid and symptoms. So the fellowship would give you all of those answers. What is the optimal zinc level? Well, you have to test, and also a lot has to do with the symptoms, right? So we not only test numbers, but we test also like how it matches clinical symptoms. That is a question for Cindy. I'd like to share this webinar with someone else. Will it be offered again? So I'll defer that to Cindy. I have a question from Jocelyn that says, I am a child and adolescent psychiatrist who sees adults as well. I like to do both fellowships. How would you suggest I begin training, general or pediatric first? Is there a program that combines both? Schedule a call and they can answer all of your questions. But my answer to that, Jocelyn, is welcome. You'll never regret it. And just start. It doesn't matter. Just get started. But you can schedule the call. That would be my suggestion. Let's see. What else? There's other questions there that are like about doses of NAC and inositol and how much do you use. I think, as I said, I don't think we have time to really answer those specific questions here, but definitely this is all seen in the fellow, like talked about at length in the fellowship. There are many other interventions that can be done. So that's good. All right.
Well, Dr. P, thank you so much. I hope everybody enjoyed hearing these case studies. This could be your practice. These could be your patients. Just a couple of things for you to know. We hold your hand for the whole year through the fellowship. We have office hours with Dr. Greenblatt and our 30-person faculty. We want you to bring your cases as you're learning. The idea is for you to learn, apply, learn, apply. We have a new AI tool that you get when you start as a fellow to use in your practice to help guide you. Again, every patient is unique, but it gives you an approach. We have a 750-person social clinical where people share case studies, resources. Once you complete our fellowship, you're in our preferred provider directory, and we get thousands of people coming and looking for folks that have been trained by us. So we share leads with you. We help you learn how to start a practice, grow a practice, blend a conventional practice with a functional psychiatry practice, how to get insurance to pay for more, what supplements from which supplement companies. I could go on and on. We're here to help clinicians help their patients. We know this works. We know this isn't what you learned in school. We're hearing more and more information coming out from the government that wants us to look at deep prescribing. We have intensives on that. It's a big part of our fellowship. We have the roadmap for you. That's what this is. We've helped 15,000 clinicians so far. And honestly, our goal is to help patients get better, and you are the conduit to that happening. We hope you'll schedule a call with us just to learn. We do offer some scholarships. Our programs are very comprehensive. It isn't for people that want to make a seven-figure salary and work 2 days a week. That's not the gist of it. That may end up being part of what happens, but the bottom line is we train you to help your patients have better chance for real lasting recovery through through functional psychiatry. Okay, we don't look at the symptoms as much as we look at the behaviors causing the symptoms. Dr. Greenblatt's been at this for 35 years, and our 30-member faculty is all here to help you. Anyway, thanks for everything today. You'll all receive an email tomorrow with a link to rewatch this on your own and yes, share it with your friends. That's the goal, to get as many clinicians as possible getting this education. Dr. Podolski, again, thank you so much, and thanks everybody for coming.
Thank you.